So how are you, everyone? Good.
Yeah, doctor, we are well. I think you are well.
Yeah, thank you. So my voice is a little bit better today. So I think still, if you have any queries, just raise your voice, give me a shout. I will try to uh, repeat that again. So according to our post that we will discuss about today's station 2 of MRCP exam and some common pitfalls of the station 2, how to start the preparation for the MRCP PACES exam regarding station 2, and what are the things you need to aware of when you are preparing yourself, and what are the most important things that you should take in your account, that when you are practicing the station 2 with someone else like your colleague, what are the most important things you need to consider. These are the things I will go through, and I'll try to make an overview of the station 2, and after that we will try to do a scenario regarding a like an exam thing in a time frame with a volunteer. And I think I already spoke with Sarwar, and he agreed to do this do the clinical scenario with me. So I think we should start. And so I'll try to share the slides for today. Just give me a moment. Is the PowerPoint is shared to everyone, isn't it?
Yeah, doctor, we
Okay,
can see it.
thank you. So yeah, as I told you earlier, that discussion regarding station 2. So station 2 is one of the most important station in the PACES exam, and it's a station that really depends on you. uh, it really depends on you, that how you do the station, like with the surrogate or with the patient, and with the also with the examiner. So it's a it's a station that depends on you. You need to control this station during the consultation with the surrogate, and also during your discussion with the examiner. So, and as I told you in my first orientation class, that station 2 and 5 are the most important two stations that needs to be cleared by any candidate to pass the exam. You can't help to miss a number in this station, and it's very important that you should carry all the marks of this station in your pocket, like 20 out of 20. And it's very easy to get these marks. And if you are getting 19 out of 20, then I'll say that you should get 1 mark less in some other skills, not in clinical communication and clinical concerns. So you need to carry almost 4 out of 4 in clinical communication, and 4 out of 4 in addressing concerns. So be aware of that. You are preparing yourself for these stations every day, almost during your preparation time, because this is very important. And sometimes this station is a very neglected station by the candidates. That's why they sometimes do very bad in this station. They thought, okay, it's like a evaluation of symptoms and some systemic inquiries and some taking some histories regarding past illnesses and some medication history. So it's easy for any graduate who pass MBBS or any kind of medical qualification. But it's not true. It's not so true that it's not an easy station. It should be a very practiced and a very thorough technique should be followed to pass this station and to carry whole mark in this station. And you need to do the lead in this station. Like your surrogate will tell you a history, but you are the interpreter. Like they will say that I'm having this problem, but you need to make sure that, oh, okay, you are telling me this, not this. Okay, like you need to make that you need to make sure that you are the leader of that station, of that consultation. You are not follow the trap or not follow the words of a surrogate or of a patient. Sometimes they can sometimes tell you some rubbish things, like they are just trying to walk in the park and just having some chat with their friends, and their dog was there, and like this kind of rubbish things sometimes they said. But you need to make sure that you are leading the station. So you need to make sure that how to stop themselves, the patient, and how to initiate the conversation, but in a professional way, isn't it? So people sometimes say, so is it always patient or is it always surrogate in the station too? So mostly in everywhere where the PACES exam takes place is usually surrogate, but sometimes patient can be in the station if it is available. But the thing is, if they are surrogate, they're really professional, they're really practiced and really experienced, and before doing the scenario with you, they already did the scenario with the two examiners who are going to assess you. Okay, so and the examiner will, like, they will have a mind setup that, okay, in this scenario the candidate should be asked this and should not ask this. He should make sure that he will prioritize these things in this station, and he will not prioritize these things in this station. So examiners already in a way they make a common approach that this should be the approach by any candidate. So they make a standard for that station. So you need to make sure that you are doing in the right way. Like you're not doing a lot of things by the book, but you are doing in a professional candidate way, and you are doing that in a very professional way, that you are covering everything and not missing the very important things. Okay, and as you know, the time framework is 20 minutes in every station. So you will get 14 minutes with the patient, and for these 14 minutes you will have 12 minutes with the patient first, and they will give a warning of 2 minutes to make you aware that there is 2 minutes remaining. Then after 14 minutes, the surrogate or the patient will leave the room, and you will have 1 minute for your reflection. And after that, you will have 5 minutes with the examiners. One of them will lead the case, and one of them will just listen. Okay. So, and in this station is a little bit different from the clinical station. Like if you start with a station one is like every time it's respiratory and abdominal. So you get 5 minutes outside the consultation room, but it's not necessary for a station 1-3, but it's very, very useful for a station 2-4-5. And you need to make sure that you are using that time in a intellectual way, in a good way, and you are not killing that 5 minutes. That 5 minutes sometimes is life-saving, and sometimes can just change the game, isn't it? So these 5 minutes are really important. you need to make sure that what should you do and what should you don't do during these 5 minutes. I found so many people, once they got the scenario as a paper outside the room in during these 5 minutes, they just under scrolls everything and everything, like every word. But that's not the right thing to do. You need to make sure that you are going through these scenarios in a sound mind quite a few times. At least try to read the scenario at least 2 or 3 times, and after that you can pick up the most important things that you should write in your paper. Okay, you should write in your paper, like the identity, name and age is very important. And if it is not patient, sometimes it's very common that you need to take the history from a relative who is the next of kin. So you need to make sure what is the relationship with the patient, and you can't address a relative as a patient, isn't it? So if you are addressing a relative as a patient, it it's the first impression that makes you like you are not giving any kind of concentration to the people. So identity is very important. Next of kin, if it is a scenario that involves next of kin, then you should make you should make sure that the next of kin has got the permission from the patient, and you are really aware that what is the relationship. It's written in the scenario. Sometimes Royal College make a note in a bracket that presume that permission has been given by the patient to the next of kin. And as time will goes by, you will learn how to note in the for the station too. There are so many performers available, and you can make anyone, like it should be in your it should be in your thought process. It should be like a proper way. A performer should be placed in your head, that I will do these things in this way, and I will cover these things. But it's not a checklist. But if still you can make some notes, like history of presenting illness, past medical history, drug history, allergies. In case of female, this pill period and pregnancy, and also some social history, social life concern. So there are so many performers available in the internet, in books. And once you are a little bit practice with this station, you will have your own catalog, or like performer, or what you are looking for. But it's not necessary. There is no hard and fast rule that this should be this, but it should be in a systematic, thorough and professional way. But you need to make sure that you are using your time, these 5 minutes, in a very important way, without making a list of 10 or 20 DDs. You need to make sure that what should the other things I need to consider, what can be the concern of this scenario, what can be the social history that I should be go through, what can be the family history that I should go through for this scenario. So these are the important things that people most often missed, and this that should not be missed. And they just write, okay, there is a there is a complaint of muscle pain, so I need to make sure that I have written 10 DDs of that. No one is going to see that paper what is your writing. After that station, they will just throw it in a bin. Okay, so no one will check your paper that either you have written 1 DD or 10 DD or 100 DD. So DDs are not so important. You can make some DDs that I don't want to forget these important differentials that I want to rule out for this scenario in a patient who is having this kind of symptoms or this kind of blood test. But you don't need to write like 10 or 15 DDs outside when you are having these 5 minutes only. So your 5 minutes is really important, because you can't do so many things. You have to do so many things, and at the same time you can't do a lot of things. Like you don't need to write or underscore every words. You don't need to write every details, but you need to write what is the identity, what is the name, age of the patient, and if it is not patient, whom I am talking to, and what is the relationship with the patient, and either that person is got the permission from the patient, either it is written in the scenario, or either that should I ask. to the patient that do you have the permission from the from your dad, from your mom, from your uncle. Okay. uh, so many DDs are not important. And as I told you, this is a history station. History is the like from our med school, from the very beginning, like in our in my country, usually from third year we used to go to the word, and all I believe that most of the time the first few rotas we just take, the seniors are just telling us that go to that bed and take some history. So from like from the early med school we are trying to learn this history taking skill, but it's very important, because it's a very important skill that will evolve every minute you are learning. So we are learning every day, every minute, every moment. But during your exam, when you are taking this history station as a clinical consultation and you can't examine the patient, so you need to make sure that you are going to make a differentials, or you are going to make a plan for that patient from this consultation, which is only based on pure history. So you can't miss so many things. Okay, like you can't miss past medical history. So many people have asked past medical history, do you have hypertension, diabetes, high cholesterol, any thyroid issues, so many things. They just give closed questions. So closed question is not a good thing. You need to ask open questions, that what are the medical conditions that you have that I should be aware of. Like this kind of sentence is very familiar. This kind of sentence you will heard from most of the online or face-to-face courses. But what I'm telling you, that you can't miss past medical history. At the same time, you should be aware of there could be some past surgical history. So you should be aware of past surgical history, and you should ask, is there any major surgical history that I should be aware of, or any minor surgeries you have undergone. So, and always make sure that in UK allergies are very important. So you can make another bold bullet, that allergies, you will ask always allergies, and what is this allergies they mean. Like sometimes they just got some adverse effect, like with aspirin they don't feel good, they just have some kind of rash, it's itchy. So this is not an adverse effect, it's a side effect. So if they tell you that I'm allergic to penicillin, you should ask that, if you had given a penicillin, what are the adverse signs that you have previously, so they can tell, oh, it was terrible, I got some breathing difficulties, then I went to A&E. So you can make a note that, okay, patient is really allergic to penicillin. So, but still, if you don't ask these things, that's fine, but you need to ask about the allergic history. And sometimes people can have allergies to few drugs, that's not a problem, but you should ask about allergies history. Many people forget to ask about any previous hospitalization, so you can make another note that what is the hospitalization history, any significant past medical condition that for that reason you need to admit to the hospital. So hospitalization is important. You can't miss about drug history. So drug history is an important thing that you should give at least near about 1 minute during your consultation, that what are the drugs you are currently taking, anything currently stopped, anything recent dose change. So when that drugs were last reviewed by any GP, or which doctors reviewed that drugs, and are you having any symptoms from these drugs, like any side effects from these drugs, or any new changes have you found in your life after starting these drugs. Okay, like any herbal medication, any over-the-counter drugs, any drugs that can interact with your these important drugs, like most of the time blood thinners. And blood thinners means anticoagulant like warfarin, sometimes aspirin, clopidogrel, ticagrelor. So yeah, so drug history is really important, and drug history you need to give at least 1 minute during your consultation within these 12 minutes. So drug history really important, and you should ask all these questions: when it was last reviewed, when it was last changed, any dose change recently, what are the effects or side effects you are having with this. People sometimes just after this drug history just jump to are you a smoker, do you smoke. So it's not a good thing to just go to the social life with a smoking questions. So but you can ask that tell me about your social life. Okay, like what is your hobbies, or what do you do during your weekend. uh, like, and now let me ask you some personal questions. That do you smoke? Do you have any habit of drinking? uh, then if it is positive that yeah, okay, he is drinking, then sometimes if it is related to your case or related to your clinical scenario, you can ask about the alcohol related questions, but not always. And you should not forget about mental health, that how are you feeling, how are you feeling mentally? Are you well? Are you feeling depressed? What about your mood? So no, don't forget about mood during the PACES exam. It's really important for the to evaluate the mental health. The other thing that sometimes people just forget that how far a doctor should go to ask about the personal life during a 12 minutes consultation. I mean, if it is not relevant with your case, you just can't jump to that. Are you do you have any casual relationship with, apart from your wife or husband? So you should be controlled, that how much should you go through. And I think once I mean, once you are a good you will practice so many scenarios, you will learn how to go through the personal life, how to be empathic, how to ask a question regarding personal life in an empathic way, and how far you should evaluate. If it is not so relevant, you can skip that. And if the examiner asks, why don't you ask that, you can have an explanation that I don't think that is necessary in this case at this moment. Okay. And for the ladies, for the female patients, sometimes you need to ask a little bit few more things that that is very important. You should ask about birth control pills, ask about what about her regular period, monthly cycle, and is there any problem she is having with that, and is she ever be pregnant. But still, these questions is like it varies from patient to patient. You can't ask everyone about all these things. I mean, you should not ask a 65-year-old woman that what about your period, isn't it? But you can ask that are you having any hot flashes or any other symptoms after your menopause, isn't it? So like as a doctor, you should be like you should think about the totality, that what you are dealing. Like in a 65 year, you don't you can't ask that what about your period, and what about your pregnancy. You can ask that do you have any kids, isn't it? So, and time breakdown is very important. Time breakdown is very important because you need to give some same importance to every part of the history. Because some people just go through the history of presenting illness, like the presentation almost 5 or 6 minutes, and then they just quickly finish this past medical, drug history, social history, mental health, social life, concern, feedback, all in a very congested, compacted way. But this is not the thing. You should make a plan, and it will be a habit if you practice in a good way for a extended time, like 3 to 6 months. It will be your habit that you are dealing with the presenting illness 3 to 4 minutes, that you are dealing with the past medical, surgical, drug history next to 2 or 2.5 minutes, then the social life 2 minutes, mood 1 minute, and then you are asking the rest, and you are giving some feedback because it's 12 minutes. So you need to make sure that you are giving importance to every part of your consultation, like presentation, background, social life, and concern. And even the feedback is very important. The what you are telling to the patient, either it is wrong or right, isn't it? I mean, if it is it wrong or right, this will be evaluated by the examiners. They will listen to what you are saying. Like, yeah, the patient is suffering from IBD, but you are telling that, okay, I think you are suffering from a disease we call celiac disease, which is a disease, which is a condition of your immune function, that your own immune system is attacking your own cells. But that's not the case, isn't it? So you are giving a false feedback to your patient, so that will not count as a good thing. And you will not get marked for this clinical communication thing, because the accurate feedback is got the marks, not the inaccurate feedback, isn't it? So, and always remember that there is always a second innings, like second chance. So when you think that, okay, already I have 5 minutes already gone, then you should make sure that which things you should not be worried about now after these 5 minutes. So every minute you can change your attitude towards the case, isn't it? Every minute you should be a more professional doctor, that, okay, I already lost 4 or 5 minutes, but I'm blank, I don't know which case I am dealing with. So you can ask the question, you tell me these symptoms, do you want me to tell me anything more? Like, always ask open questions. Open questions are best for anyone. I mean, like in your day-to-day life, open questions are good, isn't it? Like, if you ask someone that, how are you, it is good, isn't it? Or if you say that you are definitely fine, isn't it? But so always ask open questions, not closed questions. Okay, like, tell me more about your pain, not where is your pain, how severe it is. Okay, so ask about open questions, and always try to think about your second innings, second chance. So as I told you earlier, that this station assesses these five skills actually. Clinical communication, you can see that I wrote in the communication, that is the clinical in the capital letter. So why I written that? Because it's clinical communication. It's not your friendly communication. It's not your communication as a very good friend. It's a communication between a doctor and a patient. How you communicate and how you interpret a layman's term. So a layman is telling you that I'm just having some discomfort in my tummy, which could be a malignancy, isn't it? So you are interpreting it could be a malignancy, and it could be a cancer. So you are asking some other symptoms, and you got few positive symptoms and few negative symptoms, but it's still, so you are always an interpreter, and you are always a clinical communicator. So it's clinical communication that the exam is going to assess, not any other communication. So clinical communication is very important, and you will develop this skill once you practice so many cases with your colleague or with patient. Now, addressing concern. Now, in this skill, I just capitalize the addressing. So why I make this? Because most of the time, what happen if during your consultation, in the mid of the consultation, maybe the patient or surrogate just ask you a question, and you just ignore that, and you are just continuing your pro forma. So this is the thing you need to address, the concern. How you can address the concern in the mid of something that you are doing. So you can say, okay, I know that you are really worried, you got a question now this moment, I will come to this question later when I finish this I finish this taking your history, is it okay? Like, so this is the address of question, address of concern. You don't answer the answer of that question what has been asked by the patient during your history taking, but you definitely listen to that, and you definitely give an answer that I'm coming back to you, I'm coming back to you. So this is the response to the concern. Okay, so addressing concern is very important. And like in a station 2, when you are going to start, you should tell the patient that during our consultation you can stop me anytime, and if you have any questions, just ask me, and I will try to answer that. Okay, so addressing concern, address concern every time. And some people are really very vague regarding addressing concern. Like the patient can ask that, oh my god, you are telling me to admit to the hospital, so what will happen to my dog? And you are just feeling embarrassed. Oh my god, I'm a doctor, I don't know how to deal with the dog. it's your dog. So you are just like seeing around and don't give a good answer, but that's not addressing concern. So you can say, uh, I really appreciate your concern regarding your dog. So what I can do, I'm really not sure that what I can do, but I still I can ask with my senior, or I can ask with my uh, nursing in charge, or our social team, that you have a dog at your home who is alone, and let them sort these things out. What can be done for him? Like a good answer, which is really good, which is really is the answer, which is really is not a bullshit. So you need to address concern, and if it is related to the clinical thing, it should be an accurate thing. So like your patient's history and everything is suggestive of IBD, and patient is asking, so what do you think, is it a cancer? And you're saying, okay, so there could be so many possibilities, and yeah, cancer is one of the possibility. So no, that's not the thing, that's not true, isn't it? So you should tell that there are some few possibilities, cancer is one of them, but my topmost possibility is inflammation of your bowel, which should be ruled out first. And if it is not the case, then I'm really afraid to tell you that yeah, it could be a possibility, but we need to rule out first the inflammation. But it's still the cancer is in my possibility list, but I'm thinking mostly it could be an inflammation of the bowel. So regarding the clinical things, you can be a little bit vague sometimes if it is necessary, or if it is indicated in that case, in that respect. But mostly if it is like east and west, so you will not get the mark of addressing concern. And addressing concern mean you are listening. Addressing concerns mean you are listening. You should be a good listener. At the same time, you will lead this scenario. Now the differentials. So differentials are really important. You need to pick up the correct diagnosis from the good amount of history and other details. But it should not be like 10 or 12 DDs. It can be 3 or 4 DDs. That's fine. But you should try to pick up the correct diagnosis, or at least near the correct diagnosis. Okay. Clinical judgment, welfare, and safety. I'll go through the details of these skills a little bit later. So some common myths that people think, or the candidate thinks, that among these skills, 1 and 2 is usually with the patient, and 3 and 4, 3, 4, 5, 3, 4 with the examiners, and 5 is both. But it's not the thing actually. All these 5 skills are actually goes in this consultation simultaneously, and all of these things actually with both of these two groups, like the surrogate and the examiners. Okay, so you need to make sure that you are doing the totality, like from the very beginning up to the end of the station with the examiner. You need to make sure, and in every step you are a good communication. Like you need to be a good communicator. You need to address the concern. You need to make exact differentials. You need to have a good plan of management, not only the bookish knowledge that, okay, I know this IBD management in details. You can give this biologics and these other things. They will not ask you these things, never, almost never. Okay, but you need to make sure that you are involving the IBD nurse. That should be the important management plan. So now this thing, that are you lucky? So this thing is sometimes, because some people will tell you that it's a 15 minutes with the patient and 5 minutes with the examiner. So sometimes the examiners are a little bit reckless, and if they're taking the exams for a long time, so they're really bored with the exam techniques and everything. So they just don't listen. They just pass the time, and after that 15 minutes they just assess you with some questions. So is it lucky enough? So I don't think is it lucky enough, because there are some practical examples that one of the candidate has been told in the feedback that she was very quiet. although she asks everything in a with good sound, with a good volume, but so these are the things can happen, isn't it? So it's not that you are lucky or not lucky, but it's true that sometimes examiner can skip this 15 minutes conversation because it's a 15 minutes long time for that to give concentration. So try to make sure that your voice in a exact tone, in a good amount of volume, always like you're maintaining your voice in a exact pace. Okay, now this is an important another thing that you should be aware of. I have written it could be fine, as I told you in the first class, that you should think about the communication or every skills, that what are the important satisfactory performance things. So try to make sure that you print that out, the PACES mark sheet, and try to implant these words in your head, that clinical communication is assessed by this, and if you are doing all these things, this is your satisfactory performance, and you will get 2 marks from each of the examiner. Okay, and if you see that according to the mark sheet, what it says, that good satisfactory performance clinical communication with will elicit presenting complaints, systemic review, past family medication history in a thorough, systematic, fluent, and professional manner. They will assess the impact of symptoms on patients' occupation, lifestyle, activities of daily living, and they will explain the relevant clinical information in an accurate, clear, structured, comprehensive, fluent, and professional manner. So you need to make sure, and if you, when you will give the exam and you will have the feedback, you can see that they will just with a pencil, they will tick everything, they will tick over every word, they will tick, okay, this candidate has done these things, they give a good feedback with a accurate, clear, structured, comprehensive, fluent, and professional manner. So why I'm seeing this slide to you, to make sure that you are familiar with this satisfactory performance stigmas, and what are the components of this satisfactory performance. So you should make sure that all these things is like implanted in your head, and you're doing these things every time you are dealing with a patient, or you are taking a history from a colleague. Okay, sorry. Now this is another skill which will be assessed during this station to patients concerned. So you can see that what is a satisfactory performance, that seeking, detects, acknowledge, and attempts to address. So at least you need to attempt to address the concern. Like if it is related to a dog, if it is really unrelated to your medical things, but still you are trying to address the patient's concern, that you will ask someone to how to do that. Okay, confirms patient knowledge and understanding. Like if I just share, like yesterday I was doing the round, and all of a sudden a relative just came to me that this is my father's hospital number, can you tell me how is the bloods today? And I have never seen that gentleman, never. So I asked, who is your dad? Then he told me that person is his dad. Then I told, in which ward? Okay, then every details I took. Then I said, sorry, he's not a medical patient, he's not our patient. Then he just asked that, so how can I get the blood results, or how will I know that how is he doing? Then I called the nurse, but the nurse was not there. Then I called the nurse in charge, and she was there, and I asked, do you know in which department the patient is admitted to? And then they looked through their handover, and they found that it's under surgical. Then I called, can you believe the surgical team to just have a chat with this gentleman? And then the nurse said, oh, what is the bleep? Then I opened my phone, and there's the induction, and I found that the bleep is that, like any bleep number. Then I said, can you bleep this number and tell them? So this is the thing that you try to attempt. So this was not my job, this was not my patient, this was not anything, but it took almost 5 or 6 minutes of my time, isn't it? So you need to attempt, acknowledge, detect, and seeking the patient's concern. And when you are giving feedback during history station or station 4, you always need to know that your patient has been informed and he or she got the right message. So you need to check patient's understanding by asking. So we have gone through a lot, and we have discussed so many things. Can you tell me that what are the things you have understand from my consultation, so that he or she can tell you, okay doctor, you are saying that I could have some inflammation of my bowel, that should be assessed with some blood test, and you are going to talk to your tummy doctor, they are going to check me, and maybe I will need a camera test as soon as possible. So these are the patient's understanding that you need to take back from the patient. And if you are happy with that, then you are a person that, okay, that's true, that I delivered the message correctly, isn't it? And you will find that there's another skills that shows that listens. So did you read that listen? So you need to be a listener, okay? You need to be a listener. At the same time, history station is a completely will be led by you. So you need to listen, but at the same time, you will try to finish within your time and try to be empathic. And I think, I believe that you know the difference between sympathy and empathy. Like, so for these two skills, like clinical communication and patient's concern, I discuss the points which will give the satisfactory performance. Now the other three skills, differentials, judgment, and patient welfare, I have written the unsatisfactory performance. Okay, I have written unsatisfactory performance. Like, if you do these things, they will give you unsatisfactory performance, like 0. Okay, so for differentials, it is written in the mark sheet that if you formulate a poor differential diagnosis, they will not consider it's a good thing. And if you fail to consider the correct diagnosis, so for a bloody diarrhea, you are considering malignancy, C. diff, antibiotic associated thing, many thing, anticoagulant, but you are not considering IBD. So they are not going to give you mark, isn't it? Unfamiliar with the correct management plan and selects inappropriate management. So you have find a patient who got hepatosplenomegaly and anemia, who is only 25 years old, and you are saying that it could be a CLD, so I'm going to do the complete hepatic workup and going to involve our hepatologist. So which is completely wrong. It should be a hemolytic anemia, could be thalassemia. So you need to do the blood workup, you need to call your hematologist, and you need to sometimes you need to screen the families, isn't it? So this is the thing, that you couldn't jeopardize this judgment. If it is jeopardized, you will got definitely 0. And so, like for IBD, you are doing so many things, but you are not involving your gastro consultant or gastro team. And you are saying that, okay, I will give hydrocortisone, enoxaparin, and fluid, antibiotic. If it is not responding, I will give these, I will give biologics. So no, you don't need to be a master after a medicine degree, but you need to involve every people who is necessary for this patient. Because yeah, it's true that the patients who is having IBD in UK, they're really managed by so many people, like dietitian, IBD nurse, stoma nurse, so many people, you'll not believe. Patients welfare. So this is important skill that everyone gets almost full mark, like 32 out of 32, and it has been assessed by every station. So as a doctor, you should get these marks. But if you just jeopardize patient safety, that can cause you a real harm. Like some examiners are really rough, they can give you 0. So you can't give patients physical and emotional discomfort. So in a station 2, it's really nothing physical discomfort you can give, because you are not touching, but sometimes emotional discomfort. So which is a real flare of ulcerative colitis, you are saying it could be a cancer. So this can cause emotional discomfort and jeopardize patient safety. You couldn't hamper the patient safety. So until you think that your patient is safe, then send the patient home. Okay. And I think this skill will be you will get the grip of this skill by the time you will learn to practice some. Okay, I have discussed so many things. Need a break, I think. Okay, so that's the thing. Need a break. Yes, you need a break during this 14 minutes. You also need some break without a real break. Okay, so try to ask something and try to formulate some things in your brain and give yourself a break. Okay, am I in the right track? I mean, am I in the right track? This is the question of the break. And then again, you are continue the consultation. So during your consultation, try take these breaks and try to make sure that you are in a professional body language. You're trying to contact the patient with eye to eye, and the last few minutes are really important, because examiners got real concentrated again, and they're just listening. Oh, okay, what the candidate is saying to the patient. Okay, he's discussing, it could be diabetes insipidus, so he's going to manage this, and it could be related to this. Okay, so he's in the right way. So last minutes are really important. So when it is almost 10 minutes, try to give feedback, try to check understanding of the patient, and try to ask, what is your concern? What is the things you are aware of, you are really worried of? Is there anything I missed? Is there anything you want to ask me? Okay, so concern is for 2 minutes. They will give a warning shot that you have 2 minutes remaining. Most people believe that you should ask concern during these 2 minutes, but it's not true. You can ask concern at the very beginning, at 6 minutes, at 8 minutes. It's really a consultation which is really flexible, but it should be in a systematic way. So you should you be loud or quiet? So you should be in a way that is audible to everyone. If you are thinking that your examiners are quite far away, before starting, you're gonna ask that, can you hear me? But most of the time they're really near. And nowadays, due to COVID, I don't know it's happening in the like this kind of online things, so it's really nothing to worry about. So don't be quiet, okay, because they're sometimes just right. Okay, we couldn't hear anything. And what is your second innings? The second innings is the like the once it is 8 or 9 minutes, you can recapitulate, and you can just reconsider the whole things in a new way to just make it compact and make it a good score to your exam. And also the 5 minutes discussion is considered to be another second innings with the examiner. If you do very good in that part, definitely you will get the marks. Okay, so I think we should practice a case now, and I think it should be within the time frame. But if you are really struggling, that you are not happy to ask so many things, and happy to end the things, you can have that. That's really acceptable, because I know all these things, all these slides is for the beginner. And if someone is here who is a practice people, already practiced so many times, so many months, this is not for you. Actually, still you can listen. And so I think the volunteer is Dr. Sarwar, and the next slide I'm going to give you, it is the scenario. And I have written here 5 minutes, but I think for the time frame, and for the Ramadan is started in UK today. I'll try to be within 3 minutes. Sarwar, you can prepare your a little bit thoughts within 3 minutes, isn't it?
Okay, doctor.
Yeah. So this is the thing. This is a little bit scenario, and it's really a hospital-based scenario.
Okay. Okay, doctor.
Okay, you're ready, right? Okay, so I'll just try to keep the
Okay, before starting, I want to say something.
yeah
Actually, I'm very much beginner at this in the whole sorry, in the whole station.
hmm,
So please pardon me
hmm.
because about my about my all the wrong answers and wrong approaches actually.
Okay, that's
Okay, let's
fine.
start.
Okay, yeah,
Should I start?
yeah, yes, please.
Okay. Hello, my name is
Hello.
Dr. Sarwar Khan. I'm one of the doctors here. Are you Mr. Heather Andrew?
Yes, doctor, I'm Heather Andrew.
Okay. Can you confirm your age for me?
Yeah, I'm 42 years old.
Okay, all right. Can I address you about Mr. Andrew?
Oh yeah, you can call me Andrew, that's fine.
Okay, thank you. Mr. Andrew, I have heard from your GP about your some illness, like about fatigueness, isn't it, Mr. Andrew?
Yeah, so yeah, I'm having this extreme fatigue for the last 3 months, doctor, you're right.
Okay. So, Mr. Andrew, can you tell me a little bit more about it in your own way?
Yeah, the thing is, doctor, I'm having this generalized fatigue for the last I will say for the last 6 months, but it's really worryful, and I'm really about all these things for the last 3 months. And I went to the GP. GP did some bloods, and he said that it's mostly fine. But I'm really tired. I really feel tired most of the time, and from day to night, I always feel so tired, so tired. I don't have any energy to do any kind of things, and I think I don't know. I'm going through a lot. I'm just a young man, but I don't have any energy. I don't want to visit my friends. I don't want to go to the pubs. Uh, I don't have any social life for the last 1 year. Uh, I'm really broken. I'm not feeling good to work at my office, and yeah. So for the last 3 months, this is extremely hard for me to do the normal things like to do the work, to go to work, to do some shoppings, groceries. It's really tough.
Oh, Andrew, I'm very sorry to hear that. Yes, I can understand that's how it's badly affected you. I'm very sorry again. Mr. Andrew, I want to ask you some questions. Is it okay?
Yeah, that's fine, doctor.
Okay. So you noticed about your fatigueness in the last 5 to 6 months ago. Is it sudden in onset or it was in gradual? What do you think?
No, it's like it's gradual. It's like not a sudden thing. It's happening for the last 6 months, and it's not going away.
Okay, all right. And do you feel any weakness or something else like in your body alongside your fatigue?
No, I don't feel any weak actually. I got my muscles are fine. I mean, I got power, but I don't feel energetic. I feel low of energy. I feel fatigue, but my of power is fine, I think.
Okay. No, do you feel any numbness in your any part of body?
No.
Okay, that's fine. And how's your actually physical exertion? I want to ask you about it. Are you really active person or are you in a sedentary life worker?
So I mean, I work in an office as a clerk, but yeah, I do. I used to go to gym, but nowadays for the last couple of months, I'm not going because I'm feeling extreme tired. But yeah, I used to maintain my health. I used to do run by cycling and went to the gym previously.
Okay, okay, all right. Can you tell me a little bit about your sleep pattern? Is it very sound sleep, or you are struggling with your sleep?
No, my sleep is okay. I don't feel that I'm suffering from any kind of insomnia or this kind of things. But my sleep is fine. I can sleep at night, and I'm sleeping okay. I'm not too bad actually.
That's lovely. And whom do you live with in your home?
Okay, so I used to live with my partner, but we just separated for the last 1 year. So yeah, now I'm living alone in my house. Yeah.
Okay. And did your partner any time told you about your during your sleep? Is there any heavy snoring or anything like that?
No, no, never.
Okay,
No, I
okay,
don't. I don't snore. No. I don't have any problem with snoring. No.
that's all right. And what's your weight? Did you measure any time?
Oh yeah, I'm almost 60 kilo.
All right. Do you have any symptoms like any racing of your heart?
No.
Okay. Any breathlessness?
You mean shortness of breath? No.
Okay, that's fine. And do you have any pain in your any joint?
No.
Okay. And pain in your tummy?
So yeah, I mean, I have some discomfort in my upper tummy. The GP said it could be like indigestion, and I'm taking uh, this omeprazole for a lot, almost now 8 months. And also he
Okay.
gave me initially some Gaviscon for that, but it's not painful. It's really something some discomfort in my tummy, but it's not pain actually.
Okay. Did these medications help you at all?
No, no, I'm still feeling this burning, sore like things in my tummy. And the GP then said to me that he can refer me to a gastro doctor, like the tummy doctor. And I went to visit that consultant, the gastro consultant, and he advised for a camera test, but I didn't went for that because I'm really I'm really worried about this camera test. I'm really feared. As totally this is totally horrible. I think it's could be some simple indigestion that I'm taking this omeprazole, but it's not helping. But yeah, there's a thing
I
that
can,
happened previously. Yeah.
oh, I understand your situation. It must be very worrying for you. Now, okay, do you think that this pain is remain in your upper tummy or it reduced to any other side, like in your back area?
No, no, no,
Okay,
that doesn't go anywhere. Mostly
okay.
in the tummy.
So, what do you think about the severity of your tummy pain? Whether, like in scoring 1 to 10, where 1 is very minimum pain and 10 is very high pain?
So I think with this omeprazole sometimes it's manageable. But yeah, if you ask as a grading, it's kindly between
Okay,
4 and 6. It's not too bad actually.
it's fine. And do you have any fever?
I know I don't have fever.
Okay. So, what kind of weather do you prefer? Like any hot weather or any cold weather?
Oh no, I'm happy with both actually.
Okay. Did you notice any swelling of your feet?
Swelling of my feet. No, I didn't notice that.
Do you have any medical condition that should be aware of, or any surgical condition previously?
No, I mean when I was teenage, like during 18, I just had a appendicectomy, which was fine. I mean it was not a very uncomplicated one. And regarding my medical history, I don't have any medical condition that I should be aware of at this moment. I don't have diabetes or pressure. Um,
That's that's
and
fine. That's lovely. Okay. Do you have any other condition, like any condition that require blood transfusion previously?
no, never.
Okay, that's fine. And what's your mood actually? How you feel in your day-to-day life?
No, I'm feeling very low nowadays. It's not nowadays. It's for the last 1 year, and I'm really depressed. And I don't know, maybe due to the breakup with my partner, but still, I'm before this breakup, I was really very low. And during the last 1.5 year, I went to GP a couple of times, and then I had a mental health checkup with a psychiatrist for, and I used to take some antidepressant.
Don't worry, we will take care of it in your hospital again. And do you have any loss of any person of your family recently, like about in the last year?
No.
Okay, that's fine. And do you have any drug, any drug you are currently taking, other side the antidepressants?
Yeah, I just take some antidepressant, escitalopram, and some this omeprazole, and sometimes Gaviscon on and off. Not other than that, no, I don't take any other things.
Do you have any allergic to any drug or any food?
Oh, not that I'm aware of. No.
Okay, that's fine. And do you have any traveling history in recently along outside the UK in recent time?
I know. I just. I mean, I went to Portugal 3 years back, not recently.
Do you have any history of any cancer patient about in your family?
Cancer patient. My father died of some cancer in the tummy.
Okay, and are your other family members are well or having the symptoms like you?
Uh, so my no, I don't have any siblings. My mom died due to old age, and my father died of some cancer in the tummy. I'm not sure what about that. What is that? Otherwise, no, no. Yeah,
Okay,
that's.
so alongside the anxiety problem, you consulted with the psychiatrist. Uh, uh, Actually, what the psychiatrist told you about your illness? Can you remember?
I don't know. They said it could be depression, and they started with me some drugs, and they said I need to go them for a checkup, but I didn't went there actually.
Right.
I missed the
And
appointment.
right. And are you feeling well after taking of these antidepressants?
Uh, Not too much, but is yeah. I mean, I'm taking that, but it's still struggling with my mood.
Can you tell me a little bit about your social life? How you are active in your social life,
So
and what
yeah,
do you do in your free time?
yeah, so I'm really I usually work 9 to 5 in an office as a clerk. I have a lot of times to do the social life, but now nowadays I'm not engaging myself to the social life. I've got so many friends. 2 minutes remaining.
Okay, I
Uh,
want to ask you some personal questions. Is it okay?
oh yeah, that's fine.
Okay, okay. Do you smoke actually?
No,
Okay, that's fine. And do you drink alcohol?
only a glass of wine during the weekend.
That's fine. Do you have anything to ask me at this point?
No, the only thing is, doctor, I'm really worried that all these things, is it related? Like, is it cancer I'm suffering from due to this extreme fatigue? I'm really worried that could it be some cancer, or I mean, it's
Okay,
another and the other question is, should I undergo the camera test that the GP and the other doctor told once, and do I need admission today? And GP did some
okay.
bloods. Are they okay? What do you say?
Okay, thank you, Mr. Andrew, for your questions. Actually, I'm very sorry for your condition, and I'm also apologizing about some a lot of questions to you. Actually, I was trying to sort out some possibilities, and having the say, symptoms like you about the fatigueness, it doesn't necessarily means that you have the cancer. Rather, I'm not thinking about the cancer at this point. I'm thinking about some your any hormonal problem may be present in your case, and we have to sort out of also other conditions. And yeah, cancer is maybe sometimes may present like your the fatigueness or any other symptoms, but uh, about your all symptoms are not very common with the cancer, though we have to rule out these cancers also, but the possibility of the cancer is very low in your case. Rather, I should write about the possibility sequence in the bottom of the list about the cancer. But first of all, we have to exclude some hormonal problem, whether it's present or not. We have to check. That's why to rule out the possibilities, actually, I have to do some blood test. Like I want to do some complete blood count about your blood sugar level, the hormones level, especially the thyroid hormones level, your parathyroid hormones level also, with some other blood test. And
Time up.
also, if it is necessary, then I will do another test. Okay, thank you, Mr. Andrew.
Thank you, doctor. Actually, time about before 1 minute earlier. Anyway, you did good. Really appreciate your volunteer work, and really appreciate you have, it was just starting, so it's not a good it's not a bad start. I would say it's a good start. The courage to start is the most important thing in PACES or in any exam, I believe. So so now, I mean, regarding the like, this is the thing that you have got 12 minutes with the patient, then you will have a warning of 2 minutes, and then you can have 1 minute that you can reflect yourself, then with the examiner the other 5 minutes. So so these 5 minutes is the second innings. uh, we will have a 1 minute period of silence, and this discussion is the 5 minutes. Like, so during this discussion, you will ask that, so what do you think? What are the problems the patient is suffering from? Do you have any diagnosis for that, or do you have any differentials? So, do you have any differentials for this gentleman? I'm asking you,
Uh,
sir.
okay, thank you. It can be a hyperparathyroidism, or it can be a multiple myeloma, though the patient's age is very young in compared to multiple myeloma. And it may be due to other hormonal abnormalities, like if this patient has albuminuria, albumin level is very low, though the albumin level is not present in our clinical case. Any cause that lead to the hypoalbuminemia may also present about the hypophosphatemia or uh, hypercalcemia. Okay, so these are the possibilities, I think, like about the hyperparathyroidism and also the multiple myeloma. These are the differential for me.
Okay, yeah. So uh, I think I will give a feedback, like a PDF form to you, as a separate thing to you. But the things I need to address in this group session, the thing is, you have find that sometimes the clues will be in the thing, like in the scenario. Sometimes you need to pick up the clue. If you see this calcium level is little high, isn't it? 2.86. 2.86, the calcium is high, so it's the symptoms are really about the hypercalcemia. So when you find the patient with hypercalcemia, you need to ask about every details, like bones, stones, abdominal groans, and psychic moans, isn't it? So bones means any bone pain, maybe you have asked, but some few other symptoms you just miss, like you will have these things once you are more practicing. Like you will not miss anything. Like systemic review is very important. Okay, like you need to ask according to system: central nervous system, peripheral nervous system, GIT, renal system, musculoskeletal, cardiovascular, and respiratory. Then uh, so like history about water work, history about bowel, this should be asked. uh, yeah, so as a beginner, this is a good thing, that's not bad. But when you find a hypercalcemia, you should always consider this multiple endocrine neoplasia in the PACES exam. Okay, because these are the PACES favorites. Multiple endocrine neoplasias are PACES favorites. Like this patient might having a pancreatic net and a component of hyperparathyroidism. The third component is still missing, but that should be evaluated in an annual follow-up, isn't it? But you should ask about the vision, headache. You ask about headache, uh, vision, any driving problems, any side vision problems. But still it could be a possibility of men, and hyperparathyroidism should be ruled out first. And maybe you can involve your endocrine doctors, and you can do some hormonal workup. Like once the routine few blood tests has already been done, you should not tell that I'm going to do an again a set of bloods. You can do the remainings. So what I'll say, always ask open questions that you ask really good. I really appreciate that you are try to ask more, so many open questions, but try to ask more. I know this is tough during your very limited time, but try to ask open questions always. Always, every symptom, ask with open questions that tell me more about these things. uh, so and sometimes the people say that station 2 is really a very detailed history, you need to take very detailed history, but not, it's not the case. Once you have a clue that patient is going towards the metabolic medicine, you need to focus on that branch. I mean, you need to focus on that part, that you are um, focusing the endocrine thing like parathyroid and thyroid and the pituitary and the pancreas. Like, you are dealing with this axis, so you are focusing this axis, and you are definitely asking some other questions which are related to this axis. Okay, so approach oriented detail focus. So you need to make some component, or you need to make a grip that you are dealing with this complaint or this system or this phenomena um, after 2 or 3 minutes, where when you are asking, tell me more about your symptoms. And you can apologize when it's a matter of apology, but you don't need to apologize every time, because the British culture don't accept that, and they don't like that actually. So uh, and even if you can read some journals about the from the GMC, that what should be the empathic words, you will have more and more knowledge that, oh, what should I tell regarding these empathy things. So I will say in a short that history station should not be a novel, but maybe a journal or a short essay. So try to be focused in that system or in that axis, which is your case, and just ask the relevant of that system. Okay, but not a very detailed that you just get you will be lost in a ocean. So I think that all the things is really very much important with the correlation. So once you find the calcium is a little bit high, you need to ask about all of the hypercalcemia symptoms, and you need to make sure in your head that I'm dealing with a hypercalcemia with either normal parathyroid or abnormal parathyroid, raised or normal or low parathyroid. So you need to make sure that you are asking these DDs very quickly. Okay, and you're just ruling out by simple questions, that is not necessary. So once you're having a family history of tummy cancer, that tummy cancer could be a pancreatic cancer, which is, and when you find that tummy cancer, you can ask a little bit more details, that can you tell me more about your father's illness. Okay, uh, anything they can tell you, maybe a clue that what is related. Okay, uh, and the PPI, which is not improving the peptic ulcer disease like illness, it could be any neuroendocrine like gastrinoma, or like this kind of things, which is definitely, these are the history which is by the surrogate, but this is a word based case actually. uh, so, and definitely you need to ask about the you need to tell about the feedback in a layman term, that I'm suspecting that all of the symptoms you are having could be related due to one of the salt we call calcium, which is high in your blood workup by which has been done by the GP. And this salt level is maintained by one of the gland in our neck, which is called parathyroid gland. It is located behind the neck. It controls our calcium metabolism. That's why you are having these symptoms like increased thirst, increasing pee, the mental health problem, burning in your tummy, and this extreme fatigue. So we are going to do some simple blood test first to make sure that your hormone level is normal or either it is raised. Then we can involve our hormone doctor, and also we need to do a scan of your neck to rule out either it is related to that gland or not. And for the possibility that you are asking about this camera test, I think we will ask our gastro doctor to review again I think before the camera test, we can do another imaging like a CT scan or some further imaging like MRI of your tummy to make sure that we are not dealing with something else. So these are the concerns that if patient asks you about, do I need to go for the OGD? So you can say yes, go for the OGD and you will have some ulcer. But you can say no, don't go for the OGD. We can have an MRI or a functional PET or a CT, and we can just detect the neuroendocrine tumor, which can be deal in the upper GI MDT later, isn't it? So this is the address of the concern, okay? And what are the GP blood shows? The GP blood shows normal everything, but your calcium is high, and all the symptoms is related to calcium. And you need to ask about, can you tell me now what you get from our consultation today? So this is the thing that patient understand, and once patient is happy, you definitely get 20. Any questions? Anyone? I think there is some chairs. Okay, someone write men one lung squamous cell lung carcinoma. No, why lung cancer? Lung cancer or this without any respiratory symptoms are very unlikely. I don't know what is milk alkali syndrome. Is not a case of PACES. Hypercalcemia, hyperthyroidism, very good. Can be sarcoidosis, no joint pain, no cough symptoms, unlikely. History of also Addison's is very unlikely because there is no weight loss, and no, you have to ask about pigmentation. But yeah, definitely these are the DDs. But once you find a focus thing that it is hypercalcemia, you can focus on that, and you need to ask about the things that is related to the hypercalcemia. You can ask about lots of things as a fatigue, isn't it? But even anemia can cause fatigue, isn't it? But still you need to make sure that you are dealing in the PACES. And you got only 12 minutes. Hepatitis, LFTs are normal. Autoimmune, PBS. Anyway, thank you for everyone for these comments. Yeah, that's fine. I mean, someone said hypercalcemia, hyperthyroidism, men. These are the good thinking thought process. Yeah, and once you find hypercalcemia, you need to evaluate that. What are the other causes that should be considered in case of hypercalcemia? Although it's just a case scenario for the beginners, it's not an exact PACES sample case scenario, and that should be. And I didn't evaluate as a PACES examinee now today. I'll just say that it's a good beginning start, and it's a good thing to start server. I really appreciate your effort.
Thank you, Doctor.
So if people don't have any questions, so I think I need to prepare my iftar.
Okay.
Good luck.
Thank you,
And
Mr. Shahjalal, for your nice presentation and the suggestion.
thank you, and yeah, thank you everyone for joining, and I think inshallah we'll continue to do that. Thank you.
Thank you again.
Thank you.
Thank you very much. Thank you.
Thank you, everyone. Thanks for participating.